Welcome to the Talking HealthTech podcast. My name is Peter Birch. Today on the show, I'm joined by Nick White from Alcidion. No stranger to Talking HealthTech. Plenty of episodes prior in the feed, but Nick, it's great to chat with you today. How are you going?
Good to be back, Pete. As always, looking forward to the conversation today.
Yeah, look, we've covered a bit of ground on the podcast in the past, you and I, and you've appeared in summit sessions and other bits and pieces, as well as other great stars from the Alcidion team who you can find on the Talking Health Tech website. Go to the Alcidion listing there, and then all the episodes previously we've released will be there. But for those unfamiliar, Nick, people can jump back and do a bit of a deep dive into previous conversations. But tell us a bit about Alcidion and I guess, more importantly, where you're at today in 2025.
Yeah, thanks, Pete. So Alcidion, for those not familiar with us, we have a platform called My Precision that's used in acute healthcare settings and also outside the hospital with remote patient monitoring and other areas. And the platform really is an extension on many systems EMRs to provide capabilities like patient flow, clinician dashboards for patient coordination, command center capability to be able to see whole of system activities, and the platform works in real time. So a lot of the information that is out there that's available to clinicians is not in real time. We provide a real-time capability across the platform to access data that's in other systems, bring it into our system, and then present it to optimize patient experience, clinician experience, and flow through the health system. And then we extend that into, as I said before, remote patient monitoring, into emergency capability, into other specialties, and provide clinician workflows and visualization to support patient care.
Got it.
Where we are at the moment, 2025, it's an exciting time. We're introducing a lot of AI capability into the platform. It's been in there for a long time, but now we're starting to expose some of that, especially around administrative burden and reducing the administrative burden for clinicians. That's a big focus for us. And so that's an exciting part of the platform that's coming. We're completely revamping our mobile capability that we'll be talking to you about in a future episode. But that's really exciting in terms of what's coming this year, and lots more.
Well, looking forward to diving into that in future episodes. And I know in the past we've talked about patient flow and clinician workflows, remote patient monitoring, I'm sure, and artificial intelligence will be there too. But today on the podcast, Nick, you and I were keen to talk about business cases, but I'm keen to get your take on what's the go with talking about business cases in this episode today.
Well, it's an interesting one. Often people think about it and they go, "Oh, business cases, it's a bit of hard work." And I totally understand it. I've been writing business cases for many years through my career. But the idea we thought today was to go back a bit to fundamentals for helping somebody who is trying to develop a business case for implementing some sort of digital technology into healthcare, and just provide some thoughts and some tidbits on the kinds of things that people would like to include, or people would like to see in the business cases to help explain. I don't want to say justify because it's the wrong word, to explain the motivations for wanting to introduce digital technology into a healthcare environment. Because there's so much out there in terms of digital technology that could be implemented. What is going to make a difference, and what is important right now within the strategic priorities of your health system? And then how do you put that business case together and tell a story that is going to help release the funding that you need to be able to go forward? So we wanted to go back to basics a little bit, talk about some of the tools and techniques that we've used, and some of the key things that you need to think about when putting a business case together for the adoption of digital health technology.
Super valuable. I want to pull a thread on just a quick comment you made in between that, because it might help me understand your how you think about these things. But you mentioned, justification isn't the right word. If the amount of times I've heard of let's justify the business case of this particular, let's justify the implementation of this technology. Why is it important that there's that distinction for you?
I think justification is a bit of a negative word. It suggests that it's the wrong thing to do, and I'm trying to convince you that it's the right thing to do. And that's the wrong sentiment. It may well be that a business case is sound, but it's not aligned with strategic priorities right now. and so it doesn't fit with the way that the organization is going, and it's something that might be adopted at a later time or never adopted because you're going in a different direction. So for me, I think the sentiment of trying to justify something is not the right one. It's trying to put together a business case that thinks about all of the various factors and then makes a decision about, is this the right path for us going forward?
Yeah. That makes sense. And yeah, I feel like that's more than just semantics of word choices. It kind of underpins the whole culture and thinking about how the decision making goes forward. So I guess in that frame, you did say as well, there's a lot of different technology in healthcare settings that can be implemented. So maybe for the purpose of this conversation, if we framed it around patient flow, that's obviously your
Yeah.
wheelhouse amongst other things, and we hear about the concept of patient flow, how it's a pretty critical challenge in healthcare systems today. Why is it such a critical issue to address and urgent, and why is that now in 2025?
Patient flow is a national priority for Australia. When we have a look at the stories that are coming out of pretty much every health system across the country, we're all struggling with the combination of an aging population, complex chronic conditions that patients are presenting with. We have staff shortages. We know we've got staff shortages, and we've got resource shortages. We've also, part of that resource storage shortage is the stranded patient problem, where we've got people who are medically ready to leave the acute facility but nowhere to go. So we have this really complex challenge in Australia of resource constraints and patients not moving fast enough through the system that are causing the system to have less resources than we have had in the past. And as a result, the patient experience is impacted, and the clinician experience is impacted, and the costs are impacted. So how do we more effectively move patients through the system when they're ready to move through the system? And we have a suite of tools that supports that and really supports accelerated clinical decision making by having access to the right information to be able to make those decisions. That's the priority around patient flow, and we see it in the media all the time, right? We hear about ramping problems, we hear about ED overcrowding, we hear about patients being in ED for too long, we hear about patients not being seen and having adverse health impacts as a result of not being seen, or our clinicians just being overworked, and that impacting decision making. So all of these things are the I guess the noise that we hear. But what's underneath that, what's driving that problem, is essentially we've got blockages in the system. We've got, as I said, patients who can't get out of the system for some reason. We've got patients who are in the system but not moving through fast enough because their priority is not as high as some other patients, and a variety of other problems that occur associated with patient flow.
Yeah, look, pretty common problems in healthcare, and I guess in the topic of this conversation around business cases, that the concept of a business case is a obviously common tool within any industry. I know you've worked across multiple industries in your time. Why is it that it's harder to put together these business cases in healthcare compared to, say, other industries?
Look, I've been doing business cases for most of my career. I was a consultant for many years, and it was part of my job to do that. It is not part of everybody's day job to do a business case. So it's not something that comes naturally to, say, a clinician who's been a nurse for many years and has been asked to do their first business case. It's a hard thing to do. It is not easy. So for anybody who is facing this challenge for the first time, don't feel that you're alone in thinking this is a really hard thing to do. In healthcare, it's even harder. It's even more complex. And some of the reasons for that is we're dealing with life and death. We're dealing with patients who are in hospital for a critical health reason, and that could be a life and death outcome for them. We are dealing with a very complex set of stakeholders, from ethics to clinicians to, we could be impacting non-clinical resources. We've got a bunch of administrators that are involved, and then you've always got, some sort of entrepreneur or vendor who's pushing their product, who's impacted as well. So you've got a really complex group of stakeholders that you're trying to support and work through and appease, for want of a better word, and then just add more fuel to that fire. We've got a really complex funding system. And are you using grant funding? Are you using funding sources from federal governments, from state governments, from the hospital system with a surplus? Where is that money coming from, and how are you having to justify? There's that word again. How are you having to source the funding that you need for the initiative that you're trying to put together? So there is a complex set of individuals and factors that we need to consider when putting together a business case in healthcare, and that's hard.
Yeah. Well, if I extrapolate that out and think about my own experience too, it's not like if I was in a public or private, any healthcare setting, and I wanted to go into a meeting or have a conversation with a project committee or whatever and say, we need to implement this solution. And I know deep down that this is the right solution because, I see it on a day to day, the clinicians get frustrated, patients don't get the best outcomes, and just generally it's the right thing to do. I guess often in healthcare we feel like, well, that's kind of because we're good humans and we're looking after people, this is why we should implement these tools. But you can't, it's not like any other business where sometimes if you're lucky, you can be like, well, if I spend $1 here, I'm going to make back $4 here because it's directly correlated. And there's my business case that if we just more invest in it, then we'll get more money back. And we're obviously all in healthcare to return a profit for the shareholders, or maybe not. But that what's difficult in that is that the whole premise of healthcare is that humans caring for humans. And so then it brings this intangible nature to benefit. So how do you kind of think about this challenge of overcoming that bridge of proving ROI or return on investment on a solution when it can be kind of a little bit nebulous?
So I think one of the things you said there is really important at the beginning, which is that when you know something is the right thing to do, right? Just you look at it and you go, oh yeah, this is obvious. It's the right thing to do. But you have to remember with digital health that every time we say we want to spend some money on some software, well, that money's not getting spent somewhere else in the health system. We've got a constrained resource pool of funding. And so that money's not getting spent on what, maybe it's nursing staff, or maybe it's new beds, or maybe it's a new wing of the hospital. That money's being spent somewhere else. So this is often a problem within a health system to say, why should we buy this software? What is the reason that we should buy that software, and make that investment in digital health rather than spending the money directly on patient care? And that can be a hard journey for people to take mentally, in terms of thinking about it is more important for us to spend this money on digital health than some of these other things that are so critically important. And the way that you need to put that story together to explain the reason why has to be a combination of soft and hard benefits, in terms of something that you can quantify, that you're actually going to have a financial impact, but also, what is the impact on the people? What is the impact on the patients? What is the impact on the population? There's a framework, for many of us will be aware of this, but for those who aren't, there's a framework called Quadruple Aim. And Quadruple Aim looks at that combination of patient experience and the impact we have on patient experience, population health and the impact that we're going to have on population health, the financial impact that we're going to have, and finally, the clinician impact. And this is a factor that was added to Triple Aim to call it Quadruple Aim, really thinking about what is the impact on the workforce. And it's really important when we're thinking about our business case that we're able to show the impact that we're going to have in each of those 4 different areas. Equally, there's a non-healthcare framework around 4 pillars for business cases, which talks about the financial impact, the operational impact, and the strategic alignment. And then we add to that in healthcare the clinical impact that we're going to have. And that's a good framework of four different pillars as well to be thinking about as we frame the business case. So I'm going to keep going because there's a next point on this, Pete, which
Please.
is a lot of people then say, well, what I'm doing is really hard to quantify.
Yeah.
Really hard. I can't, think about how I can't figure out how I'm going to quantify the benefits.
You just don't understand. That's
Yeah.
yeah.
The first thing I would say is, what is the impact that you're trying to have? Right. And then think about doing an impact study after you've done the implementation. What's the questions that you would ask in terms of how are we going to show that we had an impact? So in patient flow, I often talk about, did we reduce length of stay? Did we reduce the number of outliers or off service, as it's known in some markets, patients, and get them back to their home ward or their target ward? Did we improve transfers within the system? So I'm asking those sorts of questions. Then I'm going, okay, well, hang on. If they're the questions that I'm asking, let's go and research whether there's any evidence out there already. Has anybody done a study already that talks about some of the statistics in this space and the impacts that can be had with this sort of software? And so having independent research, independent studies that have been done to back up some of the benefits that you're estimating is critical in the business case.
Mm. Yeah, absolutely. That's a great framework. And then, you've kind of given the thinking around, well, how you add some specifics to it. I'm going to hazard a guess and say this is the kind of approach that you look at in terms of, specifically patient flow in showing some concrete examples of the return on investment and this kind of stuff.
Yeah, look, and this applies beyond just patient flow. I just want to keep that in mind for people who are listening. But we did a podcast, you and I, a little while ago where we talked through the independent study that was done of the implementation at Alfred Health, where the Digital Health CRC and Monash University came in and studied the impact that Alfred had delivered or that was delivered through the adoption of that patient flow software. And they were able to evidence, reduced time in allocating a bed, a reduction in length of stay, an improvement in the EDDs being planned for patients, and a number of other areas around outliers and ways of working. So if people are interested in that, there's a whole podcast on that. Have a listen. But that evidence base was a first step for us in terms of being able to show an independent study of the impact that this software can have. Because it's one thing to digitize the patient record. It's a totally next step to start to think about, well, how do we use that digitized patient record, and in what ways are we going to digitize clinical workflows to have a further impact on the areas that we outlined in quadruple aim?
Yeah. And I think about too, my own personal experience, sometimes, if I get bogged down and think, or maybe deflated in the implementation of some technology, where I'm like, well, why do I need to have a graph to point at? We all know that this is the case, but I've been in examples years and years ago too, where, a new CEO or a new project manager or someone brand new into the business comes through. If you picture, well, how do you show to them, like, why did we even do this in the first place, regardless of how the project has gone? It's kind of like, well, here's the reason. It's not just because I thought it was a great idea, and that sounds obvious sometimes, but I think in the busyness of day to day, and also the emotion maybe that might come behind it too, it's to be able to bring yourself out of it a little bit and then have that kind of independence, like you say, like a study, provides a lot of weight, and that's
I think there's another. I like what you're saying there with independence, right? There's another thing to think about here, which is we can often get very, as you say, emotional about the solution that we're putting forward, right? And as an entrepreneur, I have built solutions in the past that I got very emotionally attached to and thought it was the right solution for everybody. And that's the danger for all of us. We get very passionate about the thing that we're working on. I often find it's very good to have somebody out of the finance team as a sounding board. And so we put together recently an Excel-based template for our customers to support our customers in putting together their business cases. And they can populate in their various numbers around number of admissions and the number of beds they've got and so on and so forth, right? And it pops out a number in terms of the impact that it will have. So it's a nice little tool to help people who are building a business case. But the one thing that I did was I thought, hang on, I've put this together. I need somebody else to check this and to check my work. And so I went out and engaged with health information managers, somebody from a finance team, and a number of executives actually from health systems, and took them through the logic that I had built in that spreadsheet to say, this is the benefit that I'm trying to explain. These are the people within the system or the costs within the system that I think I'm going to impact with this. This is the evidence base that I've got, and this is the calculation that I've put together that calculates the estimated impact. And I've said, do you agree? Or have I got it wrong? And by having multiple people look at that calculation and validate that, yeah, I think you've made the right assumptions there in terms of how you're putting that together, then you can have essentially a validation of your thinking.
Yeah.
I said one word in there that's really important: assumptions. Any assumptions that you've made in a business case, document them. Just have a tab within your spreadsheet or a Word document somewhere where every time you have to make an assumption, because we do have to make assumptions, that you put down those bullets and then you capture them and you put them in the bottom of your business case, because people will be looking for them. What assumptions did you make in putting this business case together? And it's just a key part to have.
I feel like I'm doing a speed run of my MBA notes from 2008 or 2009. So this is a nice refresher. Thank you, Nick. But it's fundamental, right? And something I'm thinking about too, though, is, you know, you've got all those assumptions, and that's kind of like, this is baseline, the stuff that I can measure, at least, you know, connect. This is, if this happens, then likely this will happen.
Yep.
Often, you know, because you've done something well or something has changed, then there's all these ripple effects that happen afterwards too. Like, because we lined up something further down the pipe, then all of a sudden it made something else that we didn't even expect kind of be a benefit. Have you seen anything like that on the, you know, in any of your examples, like in patient flow?
Yeah, look, we've got a story that we talk about, which we actually use the word ripple effects. And one of the things that I love about looking at patient flow is that you can change something somewhere in the system and it'll have a downstream positive impact. And the great example of that is outliers. Patients that have gone into the wrong ward at admission because of access block in the target ward. And those patients, studies show that they have twice the length of stay and a 40% higher chance of mortality. So if you think about resolving an outlier, we immediately have an impact where we've reduced the length of stay for that patient. But the ripple effect is we've also freed up a bed for another patient to be able to come into the system and get treatment. And so there's downstream effects of the things that we do that you need to take into account. So often the benefits that you deliver through certain actions will have downstream effects that can be taken into consideration of the business case as well. And those downstream effects might be as simple as what I've just said. We've freed up a bed, and so therefore we can have another patient come through the system. It might be that we've had released some time to care for care workers, nurses, and others. And then we need to think about, well, hang on, that's not necessarily just able to be how we capture that benefit and articulate that benefit then needs to be thought about. So step one, what are the downstream effects, multiple downstream effects that could be hard benefits, could be soft benefits? And then how do we capture those benefits and deliver on them? So the example I want to give is where we've released time to care, right? So a patient has a lower length of stay. So technically there is some time there that we were paying for previously that is now available. It is not a good approach to assume that you can just convert that into cash, because that's not going to happen. Usually it's an arm or a leg we talk about when we're putting business cases together of a person, and you cannot cash an arm, a leg, or of a person. Also in healthcare, we've got a critical staff shortage. We're not going to be capturing the benefit in that way typically in healthcare. We're going to be doing things like allowing staff to go home earlier and do less overtime and get to spend more time with their families and self-care. We're going to be allowing them to invest in training or in I had a story, a very personal story that was told to me recently about a nurse who didn't drink water before their shift because they felt they didn't have time to go to the bathroom during their shift. It
Wow.
is absolutely critical, the staff shortages and the pressure that our clinicians are facing, and anything we can do to give them back time is critical. So self-care is so important in this business case and story that we're putting together. We can put staff in hotspots. If we've released time to care, well, then we can have those staff go and focus on hotspots, or simply more time for the patients. Just spending more time with our patients. So anything we can do to reduce that admin burden and give staff time to care, or reduce length of stay and give staff time to care, is critical in a business case and should be expressed that way.
Yeah, totally. Hey, look, we've thought about when things go well, and what would demonstrate the return on investment on software, and kind of unpacked a few intangibles, or things that might be hard to measure. When I think of healthcare implementations, one of those big factors is, once you get your technology out onto the ground and then it's in the hands of clinicians, that's when really the real user testing comes in, right? And that you've got to sometimes butt up against well entrenched workflows, however good or bad those are. Those are just always the way we've done things, and it's not through lack of well, in my experience, often it's not because people don't want to change. It's kind of like, well, if I do this, then it's going to slow me down. I just know how to do this, even though logically, when you pull back and look at it, it's like, it's logically not the most efficient way, but there's this kind of learning curve going on. But I don't really have time for this learning curve right now, Nick. So how do you go about this kind of pushback that happens sometimes from clinicians who may be change resistant?
I would express it in a different way. I don't think they're change resistant. I think that that typically what we're facing is, I'm caring for a patient. I'm following a process that's well documented, that's been done for years, and has been shown to be successful in the way we care for patients. So we're now introducing a piece of technology or a change in the process that's upsetting that equilibrium, right? And we're looking for a new equilibrium. And so it's not that the staff are resistant to change, it's they're cautious. They're making sure that their patients come first and that care for those patients is not compromised. And that is an absolutely appropriate response when change is being introduced into a clinical environment. The key thing that we're looking for when we're deploying technology or digitizing clinical workflows is we want to make the right thing to do the easy thing to do, right? And those words are really critical, and we've used them in a number of different times when we've expressed how we do change management. If we're looking to introduce a digital workflow, how do we make sure that that digital workflow is actually not creating complexity, not adding administrative burden, not taking away from patient care? How do we make sure that all of those things are positively impacted as we introduce the digital health technology? And then how do we provide, where there is a need, an evidence base for clinicians to refer to understand that that digital health component that you're introducing is not going to have an adverse effect on patient care? An example, I'll give you an example of this right now that we've been talking about recently, is the impact of remote patient monitoring and hospital in the home programs, or virtual care programs as they're sometimes called, where we've got a patient who is leaving the hospital earlier than they normally would have and using remote patient monitoring devices in their own home and being monitored by a clinician remotely. The studies are now coming out that are showing that this is not having an adverse impact on patient care in the majority of cases, and that in actual fact it's having a positive impact on patient care because they're able to be cared for in the comfort of their own home, where the outcomes are achieved faster. They're the words I'm trying to get to. So that's an example of an evidence base which is now starting to be developed, which is it's able to support cases around remote patient monitoring. And it's really interesting to see those sorts of cases being included in a business case to justify and to bring clinicians on the journey of introducing this technology is the right thing to do for our patients.
Yeah, that is interesting, taking that view from the clinician side. If I was then to put on a different figurative hat in a hospital setting, if I'm taking the view of, the CTO or someone responsible for the tech stack within a health system, often I think about some of the tech stacks these days in hospitals, kind of like those artesian hamburgers you get from like fancy like locations in the eastern suburbs of Sydney, and they're like $45, and you've got to be like a snake to be able to like take a bite of it because it's so huge. So where was I going with this? The tech stack within some of these healthcare systems is huge, but as a baseline, you got to have your EMR, and we invest a lot into that, and there's like a PAS, and there's all these other bits and pieces. If you're creating something that's kind of a on top of, like a lot of CTOs, CIOs, people don't want to manage more complexity. I think that's what you're saying before in terms of workflows. How do you kind of find this balance between investing in some of those core capabilities and then something else?
So this is where I go back to the 4 pillars that we talked about. One of those 4 pillars was strategic alignment, right?
Mm.
And so what is the direction that the system is taking with regard to technical architecture, and how does the digital health component that you're introducing align with that strategic direction, right? And I'll take our case as an example because I know it well. We have a platform approach that we introduce Maya Precision as a platform, a fundamental component of that technical architecture. We connect with the existing solutions and bring in the data into that platform and allow the health system to have an interoperable set of data sitting in a FHIR platform called Maya Precision that they can access with our applications and other applications. So it's a strategic direction for the health system to move in that way and to adopt a data interoperability platform and then deliver these digital health capabilities on top of that platform. That's a larger story around the strategic direction that a health system might be going in. The key thing when you're doing a business case, any business case, doesn't have to be related to patient flow, could be, but could be something else. What is the strategic direction of the health system? Does the software that you're trying to introduce align with that strategic direction, or does it go against that strategic direction? If it introduces more complexity into the environment, what is the clinical reason that justifies introducing that complexity into the technical architecture? Because there may well be situations where it's okay to introduce something that is adjacent to the agenda of your CIO or CTO because it suits a specific and important clinical need. But for the most part, how do we make sure that we're traveling in the same direction as the architectural roadmap of the organization?
Yeah, that makes sense. As we start to round out the conversation, Nick, a lot of healthcare leaders within health settings that check out the podcast. If there was some key advice you'd provide to them looking at implementing technology, or maybe specifically patient flow technology, what would that advice be?
Patient flow is a word that's bandied around a lot. I think virtual care has the same problem. It means a lot of different things to different people, and patient flow means a lot of different things to different people. I think we need to go back to the fundamentals of what we're trying to deliver: data interoperability, digitizing clinical workflows, and positive impacts on both costs of the system, but also on patient outcomes associated with the health system or going through the health system. The technology that is available in this space today can deliver real-time data. It can convert data in old systems into the FHIR standard, which is our adopted interoperability standard for healthcare. It can provide capability across multiple aspects of what you're trying to do. So my advice would be to have a look at the various platforms that are out there, the capabilities that they're delivering, and ensure that those capabilities do deliver on the strategic imperatives for the organization. Those would be the key bits of advice that I would give.
Yeah, and lastly, just as you were saying that, I'm thinking, you outlined well what the current technology and patient flow can kind of do today, and there's sort of all the things that we want it to do. I'm not like, what else do we want it to do, Nick? Like, you tell me, where are you seeing the patient flow technology heading over the coming years?
and you should tell this as part of your business case as well. For those people who are still listening to us because of business cases, telling the future of the application is important as talking about what it can do today.
Yeah.
In particular, for My Precision, the platform approach around patient flow, remote patient monitoring, emergency, so on. We are absolutely looking at the AI capabilities and how we can target administrative burden. We're introducing capabilities that support the reduction of that administrative burden and reducing the amount of time that clinicians are taken away from patient care. So that is a big focus for us. Where I mentioned earlier in the podcast, mobility. We're totally overhauling mobility from our capability in the platform and introducing some really exciting new capabilities around mobility, because what we've recognized now is that having the technology in your pocket at the time that you need it, rather than having to go back to a workstation somewhere, is an evolution that's happened in healthcare. If we go back 5-6 years, most people would say, no, we're not carrying mobile phones around on the ward. Today, that's a different story. So how do we deliver the technology in a very advanced way on a mobile platform for a clinician to be able to access the information they need where they are? There's a lot more coming in this space. It's a really exciting frontier in terms of how the technology is developing. I think what we'll find is that there will be applications out there that allow clinicians to have the information they need at the point of care. So the question will be, why don't they? In any given situation, why is this information not available right now? Because there is technology out there that can make it available right now.
Yeah, doing it not just because we can, but because we should. Like that's the baseline requirement.
We should support our clinicians to have the information they need at the point of care.
100%. Hey, Nick, always a pleasure having a chat on the podcast, and people can check out the show notes of this episode for a few links and also further listing of Alcidion on our website. And there's more episodes back in the feed you can check out. But looking forward to having more conversations with yourself and others from Alcidion in the coming months on the podcast too. So thank you so much for your time.
Thanks, Pete.
We hope you enjoyed this episode of Talking HealthTech. Make sure you like and subscribe and share this episode with someone who might find it valuable. For more information and resources about healthcare innovation, visit talkinghealthtech.com.